Dr. Julien Garnon, he's at the University Hospital of Strasbourg. He's in the Department of Interventional Radiology. His area of expertise is interventional oncology and more specifically cryoablation of tumors. And he's going to be speaking to us today about IVR, which is a combination of an angiography suite with a CT scan in it and how it applies to oncology investigation. Thank you very much.
Good morning, ladies and gentlemen. It's a pleasure and privilege for me to be here today. And I would like to thank Canon for the kind invitation. So within the next 20 to 25 minutes, I'm going to try to demonstrate why this machine, the Angio-CT, can be a breakthrough solution in interventional oncology. So first of all, I'm just going to explain a little bit more who I am and what I'm doing. So here's the place where I'm working in. So it's in Strasbourg in France, near the Germany border. Very nice city if you want to come and visit me. What we decided to do here is to have a department which is dedicated to interventional radiology. That means I completely split from diagnostic radiology, so I learned a lot of stuff from the first two presentations. I'm fully dedicated, and means consultation, imaging prior and after the treatment, and of course, performing the treatment. We have also quite a nice setup with access to both cone beam CT, image guidance, Angio-CT image guidance, ultrasound image guidance, and even access to MRI and some access to TEP CT guidance whenever we think it's necessary. A word also about interventional radiology in oncology. So you probably hear sometimes the word interventional oncology, that's the same. You might know that today, when we talk about diagnosis and treatment of those patients, clearly interventional radiology is one of the pillars in oncology. You have the medical oncologist, which is the leader, and then whenever you think about performing local treatment, of course, surgery, radiation therapy, but more and more interventional radiology is a growing field to improve the patient's care. And interventional radiology can help for, of course, diagnosis through the biopsies, but also for palliative and curative treatment. And when we speak about interventional radiology, you can provide interventions, but you clearly need image guidance. And among all those image guidance tools, one of the possibilities is having access to Angio-CT, and this is why I'm here today. So as an introduction, I would like to share with you the concept of multimodality and Angio-CT with this short homemade cartoon.
Well, I don't see anything. We need to use CT guidance. Ablation completed. Everything went perfect. Oh. We need to go to the Angio suite. Quickly.
A few moments later.
Sorry guys, but there is already someone inside.
Ablation completed. Everything went perfect. Oh.
So this is not only for fun. It can also happen in the daily practice. Here is an example of a patient that we have been treating using 2 microwave needles that you can see there, bleeding just immediately after the treatment. And as you are in the Angio-CT suite, you can use the C-arm and do the embolization right away and fix the problem. That means it's a complication, but you can fix it immediately. And when the patient wakes up, of course, there is no consequence for him. So Angio-CT, this is the beast, the true CT scan and a true C-arm. And the idea of this concept is to be able to use either each modality separately or to combine those two technologies all together. And It looks brand new, but in fact, it's not. So let me refresh your mind. 1992, remember you were listening to that music. That's also the time where the first Angio-CT was designed in Japan by Professor Arai in Tokyo. So the first system, ever. And then, of course, Toshiba at that time kept improving the device. And in 2015, they launched the system in Europe. And so at that time, I will show you the system that we were using. So to do those kind of combined approaches whenever we thought it was necessary, we were using a CT scan, and close to this CT scan, a mobile C-arm. So we had access, of course, to CT images and fluoro images, but there were some issues. As it's a mobile machine, of course, the image quality was not perfect. The field of view was not as large as we would like to, and the radiation also for ourselves and for the patient was not improved. And there was no communication possible between the CT machine and the fluoro machine. So we decided to go for an Angio-CT. And just to show you that it's quite a little bit of work to get that machine installed, here is a summary of 3 months of intensive work before we were able to have the machine ready for treatment. So you can see the preparation of the room. Once you have removed the CT scan, you need to adapt the ground because the machine is quite heavy. Then you have to bring the CT first, and then they will bring the C-arm inside. Again, that's 3 months, summarized in 30 seconds. And then you get this beautiful cutting-edge technology. So just to show you the room we got in 2017, so 2 years ago, an Infinix i4D-CT, so the first system we had. And clearly, when you enter the room, this kind of room, you really feel like you're entering kind of the future, I would say. A lot of music, so I'm sure you are awake. So you already see how you can combine the C-arm and the CT scan close together. I will show you more examples right away. Also, how you can push what you're doing in terms of intervention. So we were happy with the system, and then we decided, as we knew that there was a surgical unit opening in a new hospital, to try to get a second machine. And we managed to get this one this year, so it was installed and get ready 3 months ago, an Alphenix 4D-CT, which is really the latest generation with a Aquilon 1 Genesis and the Alphenix, the C-arm, which you can see here. So coming back to what's inside that machine, so you have a true CT scan. Hopefully for interventions you would need, again, the latest technology. That means large bore to get access to the patient, having access to gantry till whenever you are going to puncture in an oblique fashion, and all the interventional interface and software available. Let me just explain a little bit more. For example, if you are going to treat that kidney tumor using cryoablation, you can see here that we are using first sequential mode. That means each time with those 3 imaging, and we can introduce our probes very precisely, and whenever we think we are ready to ablate that tumor, you can then go for a volume mode. So without any movement from the table, neither from the CT gantry, you get that beautiful 8 centimeter volume mode where you can do some kind of reconstruction, assess properly that the distance in between each probe is between 1.5 to 2 centimeter, and then proceed to treatment. And clearly, what we can do today in CT scan, we can really push the boundaries of what we are doing. You can see here that's a patient with an RCC. He's got one single lymph node there, which is not really easily accessible. You have the vena cava there, the duodenum is here, the pielo-ureteral junction is not far away. And just to show you with the precision of CT guidance today what we can do for those kind of patients, here's a kind of summary of what we did. You can see cryoprobes in position, hydrodissection. What you see here is some fluid with contrast. So you push the duodenum, you push the vena cava, you push the psoas, you push the kidney, and at the end, you can freeze that tumor and assess in multiplanar view that you are covering the tumor with safety margins. So again, that's really the key for us, being able to be sure that we are treating the tumor completely. It's also a cone beam, so with different options on the system. With, of course, so cone beam technology, you reduce the dose, you increase the quality of imaging compared to a mobile C-arm, for example. On the latest generation machine, you can also do cone beam CT with the cone beam. I'm not sure it's very helpful because you have the CT just on the side, but it's possible to do it using this. And just to show you again that you can use the C-arm, both left side, right side or head side position to the patient, and you can perform any kind of fluoroscopically guided procedure using that machine. But the true benefit of the system really comes when you are able to connect the C-arm and the CT scan together. And in order to share with you how it's like to be in the room and have those two technologies together, I would like, first of all, to allow you to take your phone. Usually we say that phones are not allowed in the room, but this time you can take it in your hands. And I'm going to share with you kind of 360 experience. So what you can do with your phone is just open the photo application. Then you can target that QR code there. Should work. And then you have a link on the top of your screen. If you click on it and you put it in landscape mode, you should have access to YouTube. And then if you move the phone on the left, on the right, up, down, or even behind you, you're inside the room. And you are able to see what it's like having the C-arm and the CT scan close together. It should work. Try with you. No, from here. So it's just make you an idea that you can switch very quickly from one solution to the other. And for those who do not have access to the video, here is kind of a global view of the system. So you see the CT scan, the C-arm. We're going to switch from a lateral fluoro position to the CT position, and you can see and count less than 30 seconds. Once we're in position, we go on the side, just to avoid radiation for ourselves. You can do the acquisition, and then immediately, if you need to come back to fluoro position, it's possible. You can store some previously registered position, and automatically you can see this is manually done when you pull out the table, but the C-arm will rotate automatically and come back in position. Of course, you have a large screen with all the different information, CT informations, fluoro informations, and I will show you also how you can use the combination and the fusion between the two imaging technology. Of course, it's interesting every time you will have to do multiple fluoro and CT control. Here is an example of a cervical cementoplasty. So you are going to access the cervical spine from the posterior approach. The pedicle is very tiny. You don't want to end up inside the canal. So you use two technologies. The fluoro helps you to have a correct codocranial angulation. CT scan nicely shows me if I stay inside the pedicle, and once I'm in, I will use the real-time fluoro to inject cement, but whenever necessary, I can very quickly go to CT and check that there is no leakage in that case. So it's not only about combining the two technologies, it's also about making a communication between the CT scan and the fluoro. So let me show you two examples. The first one will be for a vascular case. So you can see there a CT scan, which was done during planning. Enhanced CT scan, you can do that kind of reconstruction, then fuse the CT images on the fluoro using bone landmarks. And if you remove the bone landmarks at the end, you get this kind of images. So the fluoro with the CT scan as an overlay. So it's like a roadmap, but done with CT scan. And here is how it looks like inside the room. So you can see the C-arm, the CT scan close together, all information on the screen, CT information, native fluoro information, fusion imaging on that very large screen. And of course, you can push again what you're doing. Here is a case where we did a cryoablation of a kidney cancer, which was really lying in the sinus of the kidney, very central tumor. So we used CT guidance to position the probe. We needed clearly extreme precision. And what you see here is endovascular access to the renal artery in order to stop the flow in the renal artery and to enhance the efficacy of cryoablation. And again, you have all the information on that very large screen there. Another example of fusion imaging, not for a vascular case, so that's a bone intervention. You see here metastasis in the acetabulum from breast cancer. It's challenging to treat because we need to inject cement there to provide consolidation, but as there is some bone cortex which is already destroyed, there's a risk of cement leakage inside the joint. So we are going to try to ablate as much as possible the tumor before injecting the cement. If you look at fluoroscopy, this is what I would see using fluoro to get access to the tumor. But imagine if I could have the tumor visualization as an overlay on my fluoro images. So here what you can do is contour the tumor on the CT images and then put it as an overlay on your fluoro, and of course it becomes much more obvious if you compare the two images. So these are the different steps of the intervention: access to the lesion, radiofrequency ablation with two impacts, one distal, one more proximal, then inflation of two balloons to create some space for the cement, and then real-time injection of cement on the real-time fluoroscopic guidance. Same information using the fusion imaging, and what you see is when I'm, for example, pulling back the RFA needles, I know exactly where I have to stop because I know exactly what are the boundaries of the tumor. Same thing when you are going to inject cement. You see that in that case, I need to inject more cement. I need to try to fill as much as possible the tumor. And having this information clearly improve what I'm doing. And whenever necessary, of course, I can switch to CT and do some volumic acquisition and see what's going on inside the patient. For example, for needle positioning or for cement repartition, I can immediately check in 3 dimensions that cement stays well inside the bone and does not spread outside the tumor. And this is an external view of the room. Again, you can see the C-arm close to the CT scan, the wide screen with all the information, CT information, native fluoro, fusion fluoro here, and to show you how quickly you can go from one position to another position in that case, so one oblique to the other oblique, and whenever necessary, we can switch to CT scan very quickly and very precisely. So, take-home points is that you can continue to do what you are already doing. All the kind of CT or fluoro interventions that you were already performing, it's feasible with that system. What I have shown is that you can improve the precision and I think the safety of what you are doing because, again, precision is key when you are coming for complex intervention. And I also believe that you can perform new procedures that were almost not feasible before. 3 examples just to share with you how we can push the limits of what we are doing in interventional radiology. The first one will be for liver. You know that liver ablation is widely accepted as an interesting tool to ablate the tumors, especially if they are less than 3 centimeters. The problem comes with bigger tumors or tumors which are hypervascular. So here is a case of an HEC that was previously ablated there. You can see here the scare of 2 RFAs there, but there's some kind of recurrent tumor in that position. So we want to ablate, but we want to be aggressive with our ablation. So what we're going to do is go with multimodality. First of all, embolize the tumor. And here we are going to use the combination of the CT scan and the C-arm as I have shown, use the CT information as an overlay for the catheterism, and then embolize the tumor. Then, once it's done, you can go to the ablation part. So everything is done in one single intervention. Positioning of 3 microwave antenna. Here again, having that triangle is the key for the most optimal ablation. So precision, having the volume mode is very interesting. Additionally, you can see a catheter there which was positioned to inject some fluid to separate the liver from the diaphragm in order not to burn the diaphragm. And that's multimodality, the catheter, the microwave antennas, even the catheter in the peritoneum. And at the end, once you have done the ablation, you can even inject some contrast through the catheter, and with 30 mils of contrast, you have a nice CT portography which shows you the ablation. And here is the outcome for that patient. That's day 3, so huge ablation, control at 3 months, and this patient 1.5 years after is still tumor-free, and we were able to get that very aggressive ablation using the combination of the 2 technologies. Kidney, it's also very wide field of application for interventional radiology. You know that, for example, cryoablation is more and more considered as a really viable alternative to surgery for tumor less than 4 centimeters. So here is a patient that we've been treating using MR guidance. You can see there the ice ball. But the problem is we did not pay attention at the pre-op imaging, and there was some residual tumor very central inside that kidney. So this is very hard to get ablated using cryoablation alone. If you think about surgery, that requires a total nephrectomy, so it's quite a huge consequence for the patient. So having that system, maybe we can try something else. So first, position a couple of cryoprobes inside that tumor using CT guidance, and here again you did millimetric precisions to get access to that tumor. What you see there is protection of the colon and the ureter as well, not to have any unintended thermal injury to those organs. And then once you have done that, you can switch to the C-arm, and first we use the ultrasound to get access to the radial artery as the patient is prone. Then you use that C-arm just to put a catheter in the right renal artery and inflate that balloon in order to stop the arterial blood flow. You know that the surgeon, they clamp the artery when they are going to resect the tumor. We do the exact same thing. That means that while we are freezing, we stop the blood flow inside the artery in order to completely reduce the vascularization and reduce what is called the sink effect, so the convection and the dispersion of the tumor, of the heat, the cold, sorry, away from the tumor. So if you close the artery, there is no vascularization and the ice ball will be much more toxic. Same thing, that's the immediate control with the catheter in position inside the artery. You can see it's really a huge partial nephrectomy, but done percutaneously. And that's the control 1.5 years after, so still tumor-free, and we applied that technique to 7 patients up till now. And we think that could be interesting for a very central tumor where the other option is radical nephrectomy. And a final case of bone. You know that palliative treatment is bone is one of, again, the application of interventional radiology, and providing consolidation for some of those patients is the key to ensure, of course, pain palliation, but also in order to make sure they will not fracture more. So you can see that case of a C2 metastasis with pathological fracture of the basis of the odontoid process. The patient has a rigid collar, he's in pain. It's quite advanced disease, so the surgeon is not going to operate on him. Standalone cementoplasty will not really be sufficient in that case because you have that fracture, and this will not be enough to fix this fracture. So having, again, the two technologies, you can do quite advanced things. So here we are going to start using CT scan, do the hydrodissection of the jugulocarotidal space and then prevertebral space in order to be able to insert Kirschner wire inside that space. So there should be a video, yes. So here again, the precision of CT scan helps me to check that the wire goes through the previously hydrodissected space. I'm not going through the trachea or esophagus or vessels. And once I have done that, you switch to fluoro. Here is an overview of the procedure, so pure percutaneous approach. You switch to fluoro, and you can advance the screw over the wire and inject the semen under real-time fluoroscopic guidance. Here again, that's the final result. So really minimally invasive approach. Usually the surgeon, they open part of the neck to get access to the spine, but it's possible to do it completely with a percutaneous approach. So some people might say, okay, that's nice. We can do fusion, we can use fluoro, and we can use CT, but we have a system which is called cone beam CT, and it does exactly the same thing. So for those who don't know or are not aware or not familiar with the system, I just show you one cone beam CT. So I'm sorry, it's a Philips machine. Don't look. You can see here the rotation, and it gives you CT-like images at the end. So one might say, maybe this is sufficient. Is really Angio-CT mandatory? One of the key features is how quick you can access the CT images. So in that case, let's say I'm in the middle of an intervention, I use lateral fluoro, and I want to get access to CT images. I'm going to ask the technician, please, we're going to do a CT. And if we start during the same time, on the left side you have the Angio-CT, on the right side you have the cone beam CT, you will see the difference. With Angio-CT, you have to put the arm up, you go to the CT scan, less than 30 seconds, and you are ready to get the images. And once you press the button, in 1 second, you will have the images, 1 to 10 seconds, depending on which sequence you are using. With cone beam CT, we are still running the test. You know that first you have to rotate around the patient, see if there is no collision, and then only you can do the true acquisition. So here, we already have the CT images. In that case, we are still struggling to get the imaging done, and then you will have to wait for the reconstruction. So it's longer, but the next question is this really relevant? And just to try to explain you, I want to play a short video game with you. So here's the video game. That's the interventional radiologist. He's going to use catheter and needles, like I have shown. Of course, the catheters, he wants fluoro to have imaging of that. And for the needles, he wants to have the CT scan. So let's see how it goes with the Angio-CT. So that's a catheter. It's fast to switch from CT scan to angio. So, okay, we got imaging of the two catheters. Here's the needle. I can bring the CT scan and see what's going on inside the patient very easily and quite fast. Again, the switching between those two modalities is 30 seconds. So if you are going to do more controls, complex procedure, no problem, you can adapt to the situation. And at the end, for the patient and yourself, of course, you're happy because you can deal with the problem that you are supposed to resolve. So we're happy. So let's play now with cone beam CT. Same exact game. Let's go. So it's an angio, so of course, every time you need a fluoro images, it's nice. Now let's see what's going on if you need to do a CT scan. You need a rotation first as a test, and then do the acquisition. So of course, if you are going to do, I don't know, like 1, 2, or 3 controls during a 2 hours procedure, it's fine. But what happens if you need multiple controls? It becomes more tricky because you will need to adapt, and at some point, you will not be able, or at least it will take too much time for you to see what's going on inside the patient. And for the radiologist, it's quite annoying if you need a lot of time to see what's going on inside the patient. So, more scientifically said, first of all, with cone beam CT, the image quality is sometimes good, but sometimes less good. It's more dependent on artifacts, motion artifacts, and also the field of view is smaller. So again, the image quality is not always perfect. Interestingly, in that paper, they showed for TACE procedures that they were able to detect more tumors and more feeders using Angio-CT compared to cone beam CT acquisition. What about the dose also? That's an issue, and one might think that because we're using CT, we increase a lot of the dose, but in fact, it's not. If you are using properly all the tools available, you will not increase the dose, and again, that's another study using TACE, where they were able to show that because they changed their practice, if you are using, for example, fusion imaging and use it as a roadmap, you are going to decrease the number of fluoroscopic acquisition, and you are also going to decrease the amount of contrast that you are about to inject to the patient. So as a conclusion, I hope I convinced you that this machine can be a breakthrough solution in interventional oncology. Of course, the key feature is that you can do all kinds of CT-guided procedures, all kinds of fluoro-guided procedures. You can also put an ultrasound in the room. But the true benefit of the system is really if you want to push the indication of what you are doing, combining the C-arm and the CT scan to perform new procedure. We are not using that technology for all cases, but whenever we need maximal precision, again, it helps us a lot, and this is why we're so happy in the room since we have that technology. Thank you very much.